right, welcome to the Society of Hospital Medicine webinar on bedside procedure for clinicians. We are excited to offer you this resource. So during this COVID-19 pandemic, especially for many of you clinicians who are asked to manage critically ill patients. So one of the things we've talked about is that effective management of critically ill patients with or without COVID is dependent on really giving some efficient, safe, and evidence-based care. And so one of the key areas of that is in this webinar, focusing on bedside procedures. So we hope you see this as a resource in bedside procedures to support you during this pandemic, wherever you are throughout the nation or internationally. We have a large group of people joining us live here. Thank you all for joining. It's a diverse group, looks like geographically, and a variety of skill sets. We have a varying level of background on this topic, I'm sure, in this community. So some of you are doing procedures with some irregularity. Others are using it rather infrequently. And many watching are probably not even doing the procedures, but maybe even been a long time and been called upon to work in the critical care environment. So really want to brush up those skills and their knowledge and skills. So the goal today is to review ultrasound guidance with bedside procedures. And we'll review some of the highlighted recommendations from the Society of Hospital Medicine's recent position statements on ultrasound guided procedures, and also go through some COVID-19 specific applications. As I walk through some of this, SHM is actively updating its COVID-19 resource page that is developed really by frontline clinicians and various organizations. And these are freely available to support clinicians nationally and internationally during this time. So take a look at that. Lots of different things, webinars, blogs and publications, positions and policy statements. So a lot of resources there. Additionally, I want to also highlight this page. Point of care ultrasound is a key area we'll be talking about, and many hospitalists and clinicians are incorporating this into their daily practice to answer specific diagnostic and or guide performance of some bedside procedures. There are many resources on this page. I won't go into those details, but there are position statements that we will highlight today, and also other resources for training specifically for frontline clinicians. There is a CME for this, but there's also MOC for those of you attending this. This is also recorded and will be available afterwards. There are no faculty disclosures. Before I hand it off to Dr. Johnson for my co-moderator here to introduce the faculty, I want to give some housekeeping items. We will be having a focused question and answer session toward the end of this webinar. There's no chat box feature, that's been turned off. There's a Q&A feature, as you can see on the Zoom feature here. Use that to insert your questions. We will be choosing several questions and themes to discuss towards the end of this session here. With that, I'll hand it off to Dr. Gordy Johnson to introduce our faculty for today.
Thanks, Benji. And yeah, I'm your co-host with Dr. Benji Mathews. I'm Gordon Johnson from Portland, Oregon. I did have the opportunity to fly to New York to help out during this pandemic. It's been very interesting, and flying back tomorrow. Dr. Mathews is the Chief of Medicine at Regions Hospital and the Health Partner System in the lovely Twin Cities in Minnesota. He's also the co-chair of the SHM POCUS Executive Council with myself and the SIG. He was the course director for SHM 2020 that unfortunately COVID decided to change that. You can see him there on the COVID wards, and he has adopted his point of care ultrasound device into a lightsaber to strike you down if you don't don and doff your PPE correctly. So watch out if you're on the wards there in Minnesota.
Dr. Johnson, you have to talk about yourself there. Where are you at there?
This is a picture of me here in New York and with the director of IMC, which is they were doing internal deployments for New York to help out over here. So I'm at Mathews Hospital in Brooklyn, right in the center of things. But fortunately, it's markedly settled down there, and I'm flying home now. But again, a very interesting week. Okay, so on the left side of your screen there, you have Dr. Ricardo Franco Sadud, who comes to us from Naples, Florida. And he has been in POCUS education for over 10 years. He's the master of central lines. He can thread a catheter probably through the little micropores in your M95 without even hitting the walls. And he's currently working as an associate program director at NCH Healthcare in Naples, Florida. Next is Ria Dancel, who's a med-peds trained physician. She's the associate professor of medicine and pediatrics at the University of North Carolina. She's the director of the Medicine Procedure Service there, and she's also the current co-director of the POCUS pre-course at the SHM National Conference. She'll be enlightening us on thoracentesis. Next is Trevor Jensen, who is an assistant professor of medicine at UCSF San Francisco and staffs the procedure service there and works as a hospitalist. He'll be enlightening us about ultrasound use in paracentesis. Finally, Nilam Soni, and introducing him is probably similar to introducing Barack Obama at a Democratic convention to a bunch of POCUS people. He's well known. He's written the standard text, I think, for internal medicine. He's a professor of medicine and an academic hospitalist at UT San Diego and works in the South Texas Veterans Healthcare Systems. He's going to talk a bit about using ultrasound for lumbar punctures, and then also some about COVID-specific uses for ultrasound. So now off to you, Benji.
Perfect. Thank you, Dr. Johnson, with the ultrasound in the background. Perfect background there. All right. With that, we're going to do a procedure roadmap for today. We're going to talk about vascular access, thoracentesis, paracentesis, LP, COVID-specific considerations, and end with a Q&A. With that, I'll hand it off to Dr. Franco for the beginning didactic here.
Thank you very much. So what we are going to do is focus mostly on ultrasound applications in each of these procedures. So we will thread you through each of the basic skills in order to do this safely and successfully. Let's go through some advantages of using ultrasound guidance and vascular access. It is well established that it helps us reduce the risk of mechanical complications. They include arterial puncture, nerve injury, bleeding complications, and there is a well-known number needed to treat of 7 in order to decrease mechanical complications with ultrasound guidance when compared to landmarks. We also know that there is a decrease in the risk of infectious complications. If you were to use an ultrasound properly and a well-established sterile technique, you will be able to save the healthcare system $167 with the use of ultrasound guidance by reducing 1 infectious complication. And in this strained healthcare system during this COVID era, this is very useful. Can you go back one, Benji, please? We also are able to increase the procedure success rate, decrease the number of needle passes, decrease the number to cannulation. And the last one is one of our novel applications, which is helps you assess placement and assess for complications associated with your procedure. Go for the next. This is a screenshot of a online publication as we were tasked by the Society of Hospital Medicine to develop some statement, a position statement on the use of ultrasound in these procedures, and very timely so in this era where we have been called to the front lines to help in procedural guidance. So this was a review of all of the literature. These are some key recommendations that we have summarized. We developed 29 recommendations in this position statement, but the most relevant ones for this lecture are listed here. The first one that we think we should share with you is that we are strongly recommending that providers use a 2-dimensional ultrasound to evaluate for anatomical variations and absence of vascular thrombosis during the pre-procedural site selection. We also recommend that we visualize the needle tip and guide wire in the target vein prior to vessel dilation. We also want providers to use real-time ultrasound guidance and to help us in internal jugular, subclavian, and femoral vein catheterization. These recommendations are more privy to the reduction in complications. We have recommendations were also applicable for arterial access, where it reduced the first pass, increased the first pass success rates, reduced the time to cannulation, and reduced the risk of hematoma development when compared to the landmark technique in both radial and femoral artery access. We also think that we are recommending that we use ultrasound to assess for pre and post-procedure pneumothorax when we are going for the internal jugular vein and the subclavian vein. We are recommending also that if we have expertise, use bedside ultrasound to assess for placement of catheter tip in the right atrium by using the rapid agitated saline injection to help us determine that it is in place. And in the era of COVID, this has been very helpful to help us reduce the number of exposures after inserting a central line and trying to increase our ability to use the lines as soon as possible. These recommendations that I have listed here are mostly to help maintain competency assessment once we have trained our clinicians. We ask that you assess the knowledge of a target vein anatomy, that you assess the ability to identify the proper vessel and recognize anatomical variants in a person that you are training. We also ask that this person is able to demonstrate CVC insertion with no technical errors, that they are able to recognize and manage acute complications, including emergency management of life-threatening complications, and that they demonstrate the ability to track in real time their needle tip at least 5 times before they are able to attempt it in a regular patient. So here we want to divide this guidance in 3 different sections. We would like to help you in the pre-procedural assessment of the vein, in the real-time needle guidance and guide wire placement verification, and the post-procedural evaluation for complications, and in this case for pneumothorax associated to a central line. So in pre-procedural assessment, we ask that you recognize that this is a slide where we're assessing the internal jugular vein in a transverse view. We are transverse to the longitudinal plane of the vessel, and so every single vessel will be seen in a circular or semicircular shape. Your indicator should correspond to the side of your patient. So if your indicator seen in this screen as a green dot is to the left of your screen, then the indicator in your linear probe should also be on the left, on your left one placed on the patient's chest or neck. Here we are able to identify the soft tissues that have been labeled in this slide as the subclavian muscle, as the sternocleidomastoid muscle, the thyroid gland, the carotid artery, and the right internal jugular vein. This is a transverse view across the patient's chest in order to assess for ultrasound guidance in a transverse view into the axillary vein. As we know, the axillary vein and cephalic vein will join and form the subclavian vein. If you were to place the probe diagonal in a diagonal position between the clavicle and the shoulder, you will be able to assess the cephalic or axillary vein in a short axis cut. This is a view of the same patient after the cephalic vein and the axillary vein have joined to form the subclavian vein. I would like to show you some examples of pre-procedural assessment. In this patient, we are looking at the left internal jugular vein. And if you are able to notice, we have placed a color Doppler box on top of a circular vessel that seems to be on top of the carotid artery. But this is a very well-rounded, circular, smaller than carotid vessel, demonstrating what seems to be a stenosis in the internal jugular vein. We want you to be able to assess the size, the shape, the respirophasic variation and compressibility of each vein. In this case, shape sends you a clue as to the possibility of stenosis in this vein. This is the same patient after switching to the contralateral neck, where there's a large circular but clearly compressible vein, which is the one that we selected for central guidance. This is another reason for a thorough pre-procedural assessment in a patient in the jugular vein. Here we are able to see a heterogeneous structure within the lumen of the internal jugular vein, demonstrating a thrombus that seems to be either subacute or chronic. There is areas of darkness within the vessel, and we placed a color Doppler through it to demonstrate that there was hardly no flow that we could detect here. So I would like now to go to the procedural assessment or the benefits of it. Here, the most benefit is in transverse view when we are able to select the patients and when we are able to track our needle into the center of the vessel. Can you move to the next? Here, during this video, we are bouncing the needle to make sure that we have properly identified the tip within the vessel. Then we turn into a longitudinal view of the vessel. After placing our guide wire and are able to track it within the lumen of the right internal jugular vein before we dilate, to make sure that we're in the vessel that we intended to be and that we have not gone through the posterior wall. This is a still view, non-video, showing the vessel, the guide wire inside the vessel and not going through the posterior wall. Where there is a lot of benefit of ultrasound is to use it not only to place the catheter, but to assess for a complication or the absence of a complication right after. We have incorporated, if you could go to the next, we have incorporated the pre-procedural and post-procedural assessment of lung sliding every time that we place a central line. In your left screen, you're able to see two rib shadows on the sides of that image that are projecting a hypoechoic area. And in between the rib shadows, you're able to see a bright line that is shimmering with inspiration, demonstrating pleural sliding with breathing. On the right screen, you see both ribs with a bright line that does not move with breathing. You can see the soft tissues on top of that, on the upper 1/3 of that image, trying to move, but no shimmering whatsoever, suggesting that this could represent a pneumothorax. Whenever you see an absence of movement or shimmering or sliding, you should consider a pneumothorax. Once you want to confirm your suspicion using yet another technique with an ultrasound, you can use this type of modality, which is an M mode, which draws a line through your area that you are trying to identify movement through. And in the left screen, through that line that you have projected, you're able to see on the upper 1/3 on the of your screen, you see horizontal lines that are still and looking like a barcode. And on the lower 2/3 of your screen, you can see a sandy appearance with a bright line in the area that divides the barcode and the sandy appearance, and that is called the seashore sign, trying to represent the sand and where the water is joining our picture. On the right side of your screen, through that image where you suspect that there could be a pneumothorax, through the M mode, there is no evidence of sandy appearance at all, and it is a barcode throughout your image, confirming your suspicion for a pneumothorax. Here, I'm going to hand it off to Ria.
Yeah, thank you, Dr. Franco. I'm going to introduce Dr. Dancel here next to talk about thoracentesis. So welcome, Dr. Dancel.
Thank you. Thanks for having me, Benji and Gordy. So I'm going to quickly talk about ultrasound guidance for thoracentesis and a couple of my favorite recommendations from our position statement. Two things that I wanted to talk or just emphasize before I go into ultrasound guidance is one, Dr. Franco was talking about real-time ultrasound guidance for central lines. When we're talking about ultrasound guidance for thoracentesis, we're talking about ultrasound marking. Rarely I will use real-time ultrasound guidance for thoracentesis, but typically what I'll be talking about is marking before doing the procedure. And the second thing, in this time of COVID, if you're seeing large pleural effusions, large enough that you want to stick a needle in and drain it, you should broaden your differential. Typically the pleural effusions that we are seeing with COVID are small, not really drainable pleural effusions, unless there is a bacterial superinfection, and that is definitely something that you do want to intervene on diagnostically and therapeutically. So next slide. The first recommendation is that we recommend ultrasound should be used to guide thoracentesis to reduce the risk of complications. The most common one that we worry about is pneumothorax. I think we all are familiar with how to position the patient if they can sit up. Sitting up with arms over a table to kind of open up the rib spaces helps your procedure. If you have a patient that is really too weak, you can have them supine with the bed up, the head of the bed up, and then just have them kind of hug their chest so you can get to their posterior axillary line. You want to be as lateral as you possibly can. The more medial you are, the intercostal artery is somewhat tortuous, especially in your elderly patients, and the artery can actually be in the middle of the intercostal space. Whereas the more lateral you are, that artery kind of tucks up under the rib, so that you want to be as lateral as possible. You want to use a low frequency probe, so either your phased array probe or the curvilinear probe. I prefer the phased array so I can get between the rib spaces a little bit better. The marker on the probe is going to be towards the head, and then by convention, if you look at the ultrasound clip now, the marker on the screen is on the left, so that everything on the left side of the screen is cephalad and everything on the right side of the screen is caudal. So let's take a closer look at that ultrasound image. So here we go. The most important thing with ultrasound guidance for thoracentesis is to know and respect and find the boundaries every single time. So the most important boundary, my visual landmark, is what's highlighted in yellow there. That is the diaphragm. So it is a bright hyperechoic curvilinear structure. Caudal to that, you'll find your solid organ, either the liver on the right side or the spleen on the left side. Cephalad to that, usually you'll see this large anechoic space, that's your pleural effusion. But you also want to make sure you see the other boundaries. So in red, we're seeing the atelectatic lung, and you want to watch that lung kind of flapping in that anechoic space and see where it moves during the respiratory cycle. And then in green at the top of your screen, that's the most superficial boundary, is your chest wall. Everything between there, all that anechoic space, is your fluid. Okay, so even if you haven't looked at a lot of pleural effusions, you should be able to tell that these effusions are very different in size. So let's take a look at the larger one first. Next slide. Okay, so again, the boundaries. I look for them, and in my mind, I mark them out every single time. In yellow is that diaphragm on the left, or sorry, the right side of the screen, the caudal end of the screen. On the cephalad part of the screen is the atelectatic lung that's bounded in red, and then again, superficially, you see the green wall. And here, if I were overly excited with my needle and went in 6 centimeters, which I would not do, but if I did, I'm not going to hit any flapping lung with this very large pleural effusion. Now contrast that to the next pleural effusion. Here again, we have all 3 boundaries marked and outlined. And if I got a little bit overexcited with my needle, there's my animation, you can see how I could actually go through that lung and cause a pneumothorax in that case. So the minimal intrapleural distance that is safe is 10 centimeters according to CHEST and the British Thoracic Society, and that's my rule of thumb. Less than a centimeter, I'm not going to do a thoracentesis. So this is one of the randomized controlled trials that we used when we were writing the position statement. In one of these trials, ultrasound reduced the risk of pneumothorax by 90% with a number needed to treat of 9. So the next recommendation is to use ultrasound guidance to increase the success rate of thoracentesis. So there have been times when I've been asked to do a thoracentesis, radiology did chest x-ray, and there is a large pleural effusion, so it should be easy for me to do a thora, right? But this is an interesting study that we looked at when writing our position statement, Daikon et al. Asked 30 physicians ranging from junior physicians to pulmonologists to mark 172 potential thoracentesis sites in 67 patients with pleural effusions using physical examination alone. So they actually had to mark on the skin where they would go if they just physical exam. And then they used an ultrasound to see exactly what was going on in those spaces that were marked. And they found that ultrasound would have avoided a puncture on dry chest, so no pleural effusion in 2% of patients, and avoided a potential laceration of solid organs, which is kind of scary. So either biopsy of the spleen or the liver in 10% of patients compared to physical examination alone. So again, respect the boundaries. If that's the only thing that I will say over and over again and that you will get from this, is to find your boundaries. So that diaphragm, super, super important. The one thing that I train my eye to see, the flapping lung, and then the chest wall. So in times when I have gotten this slam dunk, this is going to be an easy thoracentesis, sometimes I will see this picture that's on the right side. And so it's a little bit confusing. You're not seeing that anechoic fluid that you should see. So again, I train my eyes to find this diaphragm. There it is in yellow. So caudal to that is the solid organ, the spleen. Since we're on the left side, you can see the heart beating there on the far end of the screen. And then cephalad to that is something that kind of looks like a solid organ, and that's the consolidated lung. So had I put a needle in this, you can see how you could either get a dry chest, cause a pneumothorax, or do a spleen biopsy. So the next recommendation is we use ultrasound to detect complex sonographic features. So this is actually super important, like septations and loculations, to guide clinical decision-making regarding the timing and the method of the pleural drainage procedure. So this is an example of a loculated effusion that I was asked to drain. Again, I find the diaphragm, and then what I'm doing is I'm sliding cephalad a couple of rib spaces, and this will loop a couple of times. And what you're seeing is not the simple black anechoic space. You're seeing a lot of this spider web appearance, and those are loculations. This is not going to be drained by a simple thoracentesis at the bedside. So this patient was actually sent for a chest tube and lytics. And the last recommendation, and Dr. Franco had actually talked about this with central lines, but I also do a pre and post procedure check for lung sliding before I do a thoracentesis. And he has already explained this on very quickly. I change to a high frequency probe if all I'm looking for is the pleural line. And I position myself such that I have 2 rib spaces, and then I look at that very bright line between the 2 rib spaces, and you want to see that shimmering appearance of the parietal pleura lining the chest wall and the visceral pleura lining the lung. If you see that movement there, that they are opposed to each other and they're sliding against each other, that is not a pneumothorax. So you want to see that before your procedure, and then when you're done, I lay the patient back down and I look the exact same place. Next slide. And if I see this, that's a problem. So here we have a rib on either side of the screen, 1/2 centimeter deep to that. You see the pleural line, but it's simply not sliding. So this is a pneumothorax. And then I would have to fix that problem somehow.
Well, thank you, Dr. Dancel. I appreciate you walking through that. We may have a few questions that are popping in through here. We may ask that, so keep your questions coming through, and we'll try to field some of those themes at the end here. Next, I'd like to invite Dr. Jensen to take it away with paracentesis. Thanks.
Thanks, Benji, and excited to spend a few minutes here talking to you guys about sort of our recommendations for ultrasound-guided paracentesis. Like the 2 discussants who came before me, I'm going to use the Society of Hospital Medicine position statement as sort of a touchstone and go through sort of various recommendations. We're actually going to make it through all the clinical outcomes and technique recommendations for paracentesis, but I'll be running through them pretty quick. We aren't going to address the training recommendations, which also are in that position statement, and you can access that for more information on our recommendations for how to sort of train people up in procedures guided by ultrasound. So back 1 slide, Benji. So I'm going to start with the clinical outcomes, mostly because I think it's worth thinking about why we're doing ultrasound guidance before we talk about how we do ultrasound guidance. And we take a lot of that for granted, I think, especially in the POCUS world, where my initial vantage point is that POCUS is a good idea, but that's not necessarily the case. And I think it's interesting, you know, the order of these procedures we've gone through today, the first one being central venous catheterization. It is a slam dunk to use ultrasound guidance from a huge evidence base. I think from a thoracentesis evidence base that's been building significantly, and there's a really good evidence base about around pneumothorax. The evidence base for paracentesis is more thin, and I think we just have to acknowledge that. That said, I will make a strong argument that you should use ultrasound guidance for paracentesis and talk through sort of a couple minutes of why and give some references that y'all can check on. So the first is that ultrasound reduces the risk of serious complications. The most common of that for paracentesis is bleeding. The study noted down below is a large retrospective review. And the take-home point from that is it reduces the risk of sort of serious bleeding and other serious complications from the low single digits to the low fractions of a digit. So sort of a 10x decrease. It is notable that there's not a large evidence base for RCTs in this, but the combination of the retrospective analyses, sort of the common sense that if you can see organs, see vessels, and see fluid, you have a better chance of hitting that fluid. And then other smaller studies that have sort of looked at identifying places where you would do an ultrasound by landmark or do a paracentesis by landmarks, and then going back and looking at ultrasound and seeing that lots of times there's not enough fluid or there's a large vessel in the area, I think make that a strong recommendation from our expert panel. And the other two aren't talked about as much, but I think are really important in my clinical practice, and that is that ultrasound attempts avoids attempting paracentesis in insufficient fluid. So even in those cases where you may not get a complication by sticking an 18 or 20 gauge partially through the subcutaneous tissue, it avoids going after a paracentesis that wasn't going to happen anyways, and it avoids that procedure before you even start. And then the last one, I think, is really interesting. And even in patients who have sufficient fluid, if you use ultrasound, you are much more likely to have a successful procedure. And I think in my particular case, more likely to obtain more fluid if you're approaching a therapeutic paracentesis as well. And the Nazir paper at the bottom there, I think is good evidence and is a really nice design study for both those last 2 points. So for the techniques for ultrasound-guided paracentesis, these are the 6 recommendations, and we're going to walk through each of them. I'm going to reorder them a little bit, just as how I do it in clinical practice. Next slide. And I'm going to add one in here, and that's just to talk about the probe selection. And I think in ideal circumstances, you use a 2-probe approach. You can use either the curvilinear or the phased array probe to identify sort of the underlying organs in the fluid pocket and describe sort of the fluid that you're going to go after. The point there is that you want to be able to see deep, 10, 15, 20 centimeters, in order to appropriately describe that fluid pocket in most patients. And then I think best practice adds a linear probe. And that linear probe is for high resolution viewing of the subcutaneous tissue to look at the vasculature and make sure you don't have any vessels in line of your paracentesis. You can theoretically do that with a curved or phased array probe, but your sensitivity goes up significantly if you add the linear probe. The take-home point from this slide, there are 2 take-home points from this slide. The first is that despite common opinion, killer abs and ascites can coexist, as in this patient model. But the second one is that using ultrasound to identify needle insertion point makes good sense. And so prior to the ultrasound era, there were really 2, maybe 3 points where you could do a paracentesis from landmarks, and that is the left and right lower quadrants and potentially infraumbilical. Now, these are still the preferred places in ultrasound guidance. You could theoretically do a paracentesis anywhere in the abdomen as long as you avoided vessels, avoided organs, and had a 2-centimeter pocket. But because this is often where fluid collects, this is often an area, as you can see on the right image, where you have a relatively thin subcutaneous tissue compared to some of the areas nearby, and avoid vessels, we still look at these three places first. So even in ultrasound guidance, you should evaluate these three positions first. The next recommendation is to assess the volume of the intraperitoneal fluid. So you found sort of where you might want to look for fluid. You put your curvilinear probe down on the left lower quadrant. And these are just two examples of what you may see. The one on the right is where we'll start. And I've sort of identified the abdominal wall, the fluid underneath, and the bowel. This is an example of a patient that would have a very safe paracentesis as long as they didn't have a vessel in the way. You have a really sort of 3-4 centimeter pocket. You would want to watch over time to make sure the bowel didn't float into place, and view in orthogonal planes, which we'll talk about soon. Versus the patient on the left, screen left, has ascites, right? So the fact that you can see the outline of the bowel there tells you that there is some intra-abdominal fluid, but that would not be a safe pocket to tap. Really importantly is to evaluate in multiple planes. I think this is second nature once you get used to ultrasound guidance, but before that, it's hard necessarily to think about the why and how significantly it can impact your clinical decision-making. But the left and the right images are potentially the same patient. And the thing to note is that on the left here, it appears that there's a several centimeter pocket, especially north towards the indicator, which is the P on the screen there. But if you turn just 90 degrees, you might get a much different picture. And that's because the ultrasound beam is only a few millimeters thick. And so you should view this as a sort of a 2D flashlight. And that's why you need sort of orthogonal planes. Once you've identified sort of an appropriate pocket and looked at it in multiple planes, you should switch over to the linear probe ideally and look at that subcutaneous tissue to identify vasculature. You should turn on color and ideally set it to the right sensitivity to pick up sort of slow flow rather than sort of cardiac flow or something like that. And be mindful that, a lot of the vessels here are going to be small and slow flowing. And the appropriate technique here is to make sure you angle your probe appropriately such that you have a vector from the vessel that is either going to or away from the probe. And that will increase your sensitivity significantly rather than just going perpendicular to the wall, to the abdominal wall. And the last two are just quick talking points. Once you've done that, mark the site of entry. And then it is important to mark it essentially immediately before the procedure. But the most important part of this is the patient shouldn't move before you do the procedure. And this happens a lot. You turn your back, you do a quick timeout, and the patient suddenly has rolled over into their other side. Acidic fluid is dynamic, and the pocket size will change significantly when that's done. So you want to re-ultrasound if that occurs. And this, in the era of sort of ultrasound marking and then coming back up, that is something that I think presents a challenge, and why bedside ultrasound offers a superior mechanism to do this ultrasound guided procedure. And the last thing is to consider real-time guidance for smaller, difficult to access fluid pockets. The major thing I'll say about here is I do smaller fluid pockets occasionally, but whenever I'm using real-time ultrasound guidance, I really take a pause and say, is the benefit worth the risk here? Because I think the understanding is I'm having to use real-time guidance, I'm increasing the risk, both because I feel like I need to hit a narrow pocket and that's more challenging, and also because I'm losing a hand from a procedural standpoint. So if I'm holding the probe in my left hand, I'm not doing a two-handed approach with my advancing my needle, and that makes it challenging. And I think those would, those should largely be saved for people who are very comfortable with procedures or go down to IR.
Thank you, Dr. Jensen. Appreciate you walking through that paracentesis. Next, I'm going to invite Dr. Soni to discuss lumbar puncture. Thank you.
All right. Thank you, Benji, Gordy, and everybody. Thanks everyone for joining us. I'm going to talk about lumbar puncture, and then we'll wrap up talking about some COVID-19 specific recommendations. So the general benefits in using ultrasound guidance for lumbar puncture are listed here. So compared to central lines, thora, and paracentesis, there's much less of a safety argument, but much more of a success rate and easier to do the procedure argument. So and the other interesting thing about lumbar puncture is this is the one procedure that actually has a lot of randomized trials. Patients were randomized to landmarks versus ultrasound mapping. Most of the studies were done by anesthesiologists, some by emergency medicine physicians, but there are probably about 40 or so randomized controlled trials. And so what did they show? They showed there was a higher procedure success rate. So this means roughly 6 to 9 or 6 to 10% of procedures would now be successful. So number needed to treat comes out to somewhere between 10 to 20. Fewer needle passes. So this in general is about 1 or 0.5 to 1 less reduction per procedure. So fewer attempts, fewer needle passes. Lower risk of traumatic taps. And you know, this number came down significantly. I think it was roughly around 28, 30% down to around 10%. So fewer traumatic taps. Less time to procedural success. So less time there sort of redirecting the needle in all different random directions. And I think in the studies where this was shown, it was roughly about a minute. Now keep in mind, it's hard to collect this data, right? You can imagine somebody says, okay, start the stop clock right now, go. And then, you know, you're trying to figure out how much time is actually spent on the procedure. And the last one was reduction in patient pain score. So this is also cut down by about half in the pain scales that they were using. Pretty much in all of these studies, the greatest benefit was in overweight and obese patients. In a lot of these studies, the patients were not technically obese, but they were in that overweight category with a BMI of 25 to 30. At the bottom of the slide are the two meta-analyses that compiled these RCTs. That top one, Gottlieb, is the one that showed the data that I just summarized on this slide. And that study only looked at, or I should say that meta-analysis only pulled data from randomized control trials of lumbar puncture. The paper by Scheich looked at spinal anesthesia along with lumbar puncture, but very, very similar conclusions. So that led to this position statement. So one in our series of 5 different position statements for the Society of Hospital Medicine. And this was published last June. It came out in paper in October, and there were 15 draft recommendations, and then 10 of those reached consensus. The 5 that didn't reach consensus, they're also very useful and used clinically by a lot of people. It's just they didn't reach the statistics we wanted to say that we had consensus around them. But you can look at all these online. So all these position statements are free PDF downloads. You don't need to be an SHM member. You can just go to the Journal of Hospital Medicine website and download them and look at them. And definitely look at the appendices. There's lots of great references in there. So I'm going to highlight a couple of these recommendations, and then I'm going to talk about the actual procedure. And in the actual procedure slides, a lot of the other recommendations are already wrapped into them. So the number 3 recommendation was to use ultrasound for selecting and marking a needle insertion site just before performing the lumbar puncture in either a lateral decubitous or sitting position. And similar to the other procedures we talked about, the patient should stay in that same position. So of the procedures we talked about, this is probably the most tedious procedure to mark. You really have to take your time. Oftentimes when people are learning this, they rush through it and they just want to get it over with. And so, you know, the old saying, garbage in, garbage out really applies here. If you rush through the markings, your markings are going to be off. Just imagine you're putting this needle in somewhere between 5 to 6 to 9 centimeters. And so if your trajectory is off, as you go deeper and deeper, you're going to be way off as you get deeper. So you really had to mark them carefully. The second recommendation I wanted to highlight is you should map the lumbar spine. Typically we'll start at the sacrum and come upwards. And we can use this to help us figure out which space we want to go into, which one looks the widest. The number 7 recommendation that I wanted to highlight is that we can use ultrasound to measure the depth to the ligamentum flavum. So this is something our magical hands just can't do. And I've been surprised at how you know, young, muscular individuals can have really big back muscles and actually have a much deeper depth than I would have anticipated. And the reverse. Sometimes you think people are going to be really hard because they're obese, but in the midline of the back, you don't really pull a lot of fat, and so the space to get into their to the ligamentum flavum is actually not that deep. So I think it's helped us in many ways. So what are we doing with ultrasound guidance for lumbar puncture? We're doing site marking, similar to paracentesis, similar to thoracentesis. What we're looking for is the widest interspinous space where we feel the most comfortable putting the needle in. We're going to want to mark that interspinous space at least in two planes, so a long axis plane and a transverse plane. And then we can slide over to a paramedian view to measure the depth of ligamentum flavum. A lot of people ask about real-time ultrasound guidance for LPs. There are a few papers out there. They're observational, prospective papers, mostly done by Paul McCarty. He's up in Toronto. There isn't a lot of literature around this, but it is being done. And the probe is basically angled with the top portion on the midline and the inferior portion out laterally, and you come in from a side at an oblique angle. Do I think the literature one day will show that real-time guidance has more benefit or a better benefit than site marking? I don't think so. That study hasn't been done, but I think that if you carefully mark the patients and take the time and be patient in marking them, your success rate is going to be really high. So to review the anatomy a little bit, so we all remember our spinal cord ends are on L1 to L2, so we can safely tap between L2 to L3, L3 to 4, or L4 to 5. Take a look, I didn't appreciate this until doing a lot of lumbar punctures, but take a look at that L4 to 5 interspinous space. It's a little bit narrower, and that's also where people tend to get more degenerative disease. So that space tends to be deeper and narrower, and in many cases hard to get to. So I think our go-to spaces are L2 to L3 or L3 to L4. But the beauty of using ultrasound is you've got options. So you can pick and choose which one you want to go for. Or maybe you say, this looks like it's going to be very difficult and I need to get either somebody better skilled than me or refer the patient to somebody else. Those two red arrows on that last slide was showing the midline approach. That's our traditional approach that we've taught in internal medicine, where you go through the interspinous spaces. But keep in mind, there's a paramedian approach. Anesthesiologists have been using this for decades, and they do it blindly. And if you look at the hole that you're trying to get into, it's actually more exposed and bigger from a paramedian approach. And we'll come back to that later on in the slides. So this is what we're doing with lumbar spine mapping. We're mapping out the spine and looking at the spinous processes in a transverse plane and a longitudinal plane. When we start off in a transverse plane, it helps us figure out where the midline is. So if you look at that video that's playing in the upper right-hand corner, you see this dark black shadow in the center. The only bone we have in the center of the back that's going to give us a shadow is the spinous processes. So when you see that dark vertical shadow, you know you're in the midline. And then on both sides, you see big, thick erector spinae muscle. And you can appreciate the tip of the bone will light up every now and then as a bright white line. So once we know where the midline is, so we start at the sacrum, we can slide up, we can assess for any scoliosis. And then once we have a sense of where the midline is, we can rotate to a longitudinal plane. So now the probe marker is pointing with the notch up towards the patient's head, and we can assess the interspinous spaces. So in that lower right-hand image, you see these two rounded humps, and those are our spinous processes. So with this longitudinal view, we can figure out which interspinous space looks the easiest to us and which one we want to select. So we make a mark vertically and then also a mark horizontally. Some practical points, these marks are going to come off when you use chlorhexidine, so you'll want to mark them with a needle cap or something to make a skin indentation. You can also extend the marks out laterally or superiorly so that it will go past your drape. So if you need to peek underneath your drape, you can take a look and see where your original markings were. So you don't have to mark all the spaces, but the advantage of seeing all of them is you can make an informed decision about which one you want to go for. If you're not confident that you're going to get it in one space, you can actually mark the two widest ones that you see. Again, the patient has to stay in position. If they move, the skin will shift and your markings will shift. And in certain cases where we've had difficulty in a lateral decubitus position, we sit the patients up and have them lean forward over a table, just like you would do for a thoracentesis in a sitting position. This helps for a couple of reasons. That people's anatomy just tends to get more symmetrical, and so the spine sort of straightens out. A couple other pearls. If you're doing an lateral decubitus position, inflate the bed, make it hard. You can put a backboard underneath the sheet also. you could use the chest compression board off the crash cart and just slip it under their hips, because you're trying to align the shoulder girdle and the pelvic girdle, and when they're twisted, the spine gets twisted, and so your skin markings can be off. Going back to our anatomy slide, so we can see down to the ligamentum flavum every now and then in between the spinous processes, but we can actually see the ligamentum flavum better from a paramedian view. But another important pearl here is if you're in the midline, you're going to be going through all these dense ligaments, supraspinous ligament, interspinous ligament, and then through the ligamentum flavum. So you should feel a fair amount of resistance as you're pushing the needle in. So a lot of times, we'll hear trainees say, well, I think it's going in, but it's really kind of hard. And you got to put a fair amount of force sometimes in young people who have really strong ligaments. And as long as the needle is going forward, you're actually in the right space. If the needle's going in easy, you're over to one side. You're in the muscle somewhere. So you need to change your angle. So this is probably the biggest pitfall of using ultrasound. People will see these rounded humps on the ultrasound screen, and those are going to be either the lamina or the articular processes. And I'll show you an anatomy slide in just a second. But the important point here is if you're seeing bone and then up here's the skin surface at the very top, and if you're seeing a lot of feathery muscle in between the bone and the skin surface, you're over to one side, and that's all erector spinae muscle. So you need to slide over to get right into the midline. But the beauty of this view is we can see this bright white line. This is the ligamentum flavum. So using this paramedian view, we can actually measure the depth down to ligamentum flavum to make sure our needle is long enough, especially in an obese patient. So this next slide, just to review the anatomy. So just to show you again where we were, here's that midline where the hole is actually fairly narrow when we're right over the spinous processes. But when we go to a paramedian view, it's a very subtle slide over to one side. You're able to see right through this hole down to the ligamentum flavum. So this is what a paramedian view looks like, and you can appreciate all that feathery muscle towards the top of the screen. You see the bone and the bone shadowing from the middle of the screen downwards, but if you're seeing a lot of feathery muscle, you've slid over to one side, so you need to slide back over. Just keep in mind, in the midline, you're gonna have skin, a little bit of subcutaneous tissue, and then you're gonna see the spinous processes. You don't have muscle in the midline. It's probably the biggest pitfall and mistake we see. But like I mentioned, from that paramedian view, we can freeze the image. For any of these procedures, whenever you're going to measure the depth, relax your pressure on the skin, freeze the image just before you come off the skin, and then measure the depth. If you're pressing hard on the skin, you're going to falsely reduce the depth. But down here, we've got the lamina. Here's our ligamentum flavum, this bright white line. This dark space here is where our cord is sitting. And then on the other side, we can actually see the anterior dura, which tends to light up bright white with the posterior longitudinal ligament, which is the backside of the vertebral bodies.
Thanks, Dr. Soni, for walking through that. We're going to actually keep you online here for the next piece. This is in the setting of a COVID pandemic, so love your reflections on COVID-19 considerations surrounding our bedside procedures. So why don't you take it away from there?
Sure. Yeah. Before I jump into my slides, I wanted to highlight a couple of things brought up by the other speakers. So Dr. Franco mentioned for central line placement, you can confirm the placement using a rapid right atrial swirl. So you flush 10 cc's or more of saline in there, and you should see a big gush of fluid entering the right atrium instantaneously. If it takes more than 2 seconds, the tip of the catheter is somewhere else. The other reason we order x-rays post-procedure is to check for pneumothorax, which he and Dr. Dancel showed you that if you see sliding bilaterally pre and post-procedure, you don't have a pneumothorax, and then you don't necessarily need to get that follow-up chest x-ray if the procedure was simple and uncomplicated. So a couple important considerations, and we'll open up to questions. So training, so everybody's being asked to step up, and who can we train safely, and how do we do this? And I think I've heard this word used a lot of tier 1, tier 2, tier 3. So some people say, hey, I'm doing this procedure. I've been doing it blind for many years. I just need help with the ultrasound. We can get those people trained. Maybe the second tier is people say, hey, I used to do this procedure, but I haven't done it in many years. We can probably get those people trained too. The ones that say, I've never done the procedure, I don't think it's worth the risk and time and commitment to try to get them trained up in doing these procedures. I think we have other people available in the hospitals. We can tap into anesthesiologists or surgeons, radiologists, et cetera. But I think most people are falling into that tier 1 and tier 2, especially the hospitals that are out there. As far as training components go, there's a variety of things that are out there, and I'll show you some free and available stuff on the internet in one of the last slides. But people are repurposing a lot of the lectures and reading material that they have for their residents and students and fellows, and giving it more towards the faculty who are staffing these patients. So readings, online lectures, and modules. If you have simulation equipment available, it's great to do simulation-based practice, at least to raise the confidence level of the operators. Something really, really important that comes up is reviewing the kits, because sometimes if people haven't done these procedures in a long time, they're just not familiar with how the kit works, and that causes a lot of anxiety. And then ideally, you want to have some observed performance time while the person who hasn't done a procedure in a while is doing it on a patient. And this is where we can use some of this tele-ultrasound software, not just for actually helping with the procedure or helping with the decision-making around the procedure and guiding people who are all PPE'd up, and the person who's the ultrasound expert or more knowledgeable is actually outside the room. So the next slide shows you some of the software that's out there for tele-ultrasound. So these are commercially available products, IIT Reacts, and using the Butterfly IQ app. The one on the left is showing some training, so people can log in from anywhere they've got internet access and be guided through a procedure, or even just doing training using this remote tele-ultrasound software. The one on the right is actually an image from Dr. Jensen when he was just in New York and actually coaching imaging on a COVID patient. And you can see the B lines there in the image in the patient that's COVID positive. Last slide here on important considerations, disinfection. So this is really nothing new, and fortunately we've got lots of disinfectants we can choose from. But the important difference now is the recommendations are to clean the machine before leaving the room and after leaving the room. And the wet times are similar to other recommendations. For bleach-based wipes, it's 1 minute. If you're using the super sandy cloths, these are the purple top sandy cloths, it's only 2 minutes, and then most other disinfecting wipes are around 3 to 5 minutes. Other important considerations: how do I put on that sterile gown with my PPE? So this is going to depend on your institution. So talk to your colleagues and figure out the best plan here. Talk to somebody who's done the procedure ahead of you. And then, last comment around anticoagulation. So we're fairly aggressively anticoagulating these patients. About a third or so are having thrombi, mostly venous and some arterial. So what could we do to reduce the risk of bleeding and potentially bleeding in a patient who doesn't have ready access to going quickly down to IR for embolization or other things that could stop the bleeding? So we can use smaller gauge needles and needle catheters. So instead of going for that big harpoon, the 8 French harpoon that's like a 1.5 feet long, go for the smaller needle catheter that's 4 to 5 French. The drainage will be slower, but at least you reduce the risk of hitting a vessel. I think both Dr. Jensen and Dancel talked about looking for vessels before you poke through the skin. It takes an extra minute, but it can really be life-saving. There's a paper by Jeff Barsick that was in JHM a few years ago, and about 10% of patients had vessels where the anticipated needle site was for paracentesis. And looking with a vascular probe in about 10% of patients, it changed where they were actually ended up inserting the needle. And then having some other things handy. So having Surgicel, that's a brand name. It's cellulose. And having that handy can help with superficial bleeding. It's like gauze, it melts over the bleeding area. Great for arterial lines. Put it on the arterial line if it was tried, and raise the arm up, the radial artery up, and the bleeding will stop. And then also using some lidocaine with epi can give you some local vasoconstriction. Here are some of the training resources and disinfection resources we have out there. The last one at the bottom there, Ernie Fisher, who's in Washington, made some nice videos on how you could cover your handheld ultrasound devices with probe covers. Some people are doing this to cover their handhelds before they go into the room, but then still disinfecting them with the sanitizing wipes after they come out.
Well, perfect. Thanks so much to Dr. Soni and team for covering that. That was a fire hose of information, but hopefully people pick things up. We've been getting a sequence of questions coming through. We'll try to pick a few themes. We're right at the top of the hour here, so we may just do a handful here and wrap it up for the session here. So with the first one, I was actually going to ask Dr. Jensen, my co-moderator, to field the first one. So go ahead.
Well, Dr. Jensen, first one's pertaining to you. I got some bad news. I was covering your pager and you sent a patient down to radiology to get a paracentesis, and they've called and said the INR is too high. You have to infuse the patient with FFP and get the INR less than 1.5. Do you have an INR that you use as a cutoff before you do a paracentesis?
Yeah, thanks, Gordy. I think my short answer is not really. The longer answer is that it's nuanced. I will say that we used to have a cutoff of INR of 2 and a platelets of 50 when we used the larger sort of trays that we had in our hospital, which were an 8 French catheter. We've liberalized that a bit. Even with that tray, we now will go up higher, specifically with sort of like our our liver transplant patients, where we have a higher INR of 3 that's acceptable. But more and more, I think we've found that our patients often have INR and platelets that aren't acceptable to tap, but need a paracentesis. And so we have moved towards sort of case-by-case evaluation using smaller angiocats, so 18 or 20 gauge angiocats, and really evaluating on a case-by-case basis and looking at sort of their bleeding profile with INR, platelets, and their renal function, and sort of considering products and how they've responded to products, and sort of taking a really comprehensive view. So the short answer is no, but I think the major take-home point is to consider the size of the catheter and then like the comprehensive bleeding profile. And obviously to sort of ask your colleagues and be mindful that with changing parameters does increase the risk.
Dr. Dancel, would you mind addressing that for thoracentesis as well?
So a lot of the thoracenteses that we do are hepatic hydrothorax. So it's sort of the same as sticking a needle into the belly for a paracentesis. If it's a patient with cirrhosis and a hepatic hydrothorax, you know, they are going to have an INR that's out, and their platelets are probably going to be low. As Dr. Soni has talked about, some of the needles in the kits are actually quite large. And so I opt not to use those. I use a smaller 5 French 10 centimeter needle or angiocath type of a system rather than the large ones that we have in the kit. Obviously, we do pause if someone is on a DOAC or if they're on clopidogrel. And I think you have to sort of practice within what is acceptable in your institution across procedural services in your institution. So we can't do anything that's very different from what VIR does or what interventional pulmonology does. So we all try to get on the same page regarding bleeding risk.
Perfect. Thanks, Dr. Dancel and Dr. Jensen, for covering that. Next question, I'm just trying to pick out themes here before we move. We'll see if there's any more that come in. Feel free to type in your questions. Those are still on the webinar here. This next one is going to go to Dr. Franco. How do you troubleshoot when the guide wire is not threading through the needle and the vein appropriately? Any tips on that?
So if you have already verified that you're in the center of the screen and your guide wire is not threading, there are 3 possibilities. First, you advance the needle or remove the needle inadvertently. So before I fumble and destroy the guide wire, I take one look and make sure that I'm in the vein. And if I am in the vein and I'm able to advance it and I'm able to go the length that I would expect, I suspect that I have not diagnosed a stenosis that is mainly at the level of the junction of the internal jugular and subclavian vein. So I first look for those obvious causes, and if none of those are there, then I just very slightly traction the needle back and try to advance, and either of those 3 things will result in success almost every time.
Perfect. Thanks, Dr. Franco. Dr. Johnson, do you want to cover any of the other ones
Yeah,
here that we see?
One quick point, you guys alluded to checking lung slide before and after procedure. I'd just like to say I learned the hard way. You need to check before to make sure it's there.
Yes.
I got very nervous when I didn't see it after procedure, thought I caused the pneumo, but the guy just had a bleb. So addressing that. And then just really quick to Dr. Soni, do we always need to save images when we're doing these procedures?
So for sure for billing, you got to save at least one image. I know it's for good care, we should probably save several. I think it depends on the procedure. For vascular access, we you know, our speak now forever hold your peace moment is when that guide wire's in before you dilate. And so you want to, I would say at least just save that image to prove to the world that you had the guide wire in the vein and only in the vein. So for billing, you need to have at least one image that could be looked up if you got audited. For good practice though, I think it's good to show the pre-image, the post-image, and then at least if you can save some during the procedure, especially if it's real-time guidance that you're using. So again, why do we get chest x-rays after thoras or even paras, or why would we do, I'm sorry, not paras, central lines? We can basically replace that chest x-ray with ultrasound to answer the same questions. So.
Perfect. Thanks, Dr. Soni. I think we're coming to the close of the session here. I want to just leave a little bit of final pearls or tips from each of the panelists, if you have any final pearls. Otherwise, I'm going to have Dr. Soni do some final tips for our session here, and then I'll give you some final remarks on these CME and MOC pieces here. So first, the panelists, any other tips?
I would say that I agree completely with Gordy. If you're gonna check for a pneumothorax, never forget to do it before. All of us smiled. You saw that because it has happened probably to all of us, where we are like, oh, okay, I don't know if this is me or I should have looked before.
Perfect. All right. Well, with that, I'm going to give Dr. Soni some final words here for the group here. As we kind of listen in, we're doing a pandemic here. Many of us are moving into the ICU, or at least prepping into that world. Some are doing a ton of procedures, others are not. And so what final tips do you have for this group as we kind of close?
Yeah, just adding on to what Dr. Franco said. If you see sliding, you can rule out pneumothorax. If you don't see sliding, it could be pneumothorax, but it could be a bleb, it could be mainstem intubation, mucus plug, et cetera, et cetera. There's a lot of things. If you see sliding, though, you can rule out pneumothorax, and that's that nice shimmering pleural line. So just going down the line, for vascular access, the big benefit of ultrasound is you can rule out thrombosis. Physical exam can't pick that up. You can reduce the complication rates, and you have options. You can choose which vessel you want to go into. For thoracentesis, most important thing, you gotta be confident with seeing the diaphragm. You gotta be able to know where the diaphragm is. In these COVID patients, we've seen the diaphragms way up to here, like all the way up to their chins. And so you'd be surprised at how high they are. And you could, if you're percussing, well, liver or spleen is gonna be just as dull as a pleural effusion. So look with ultrasound before you stick. And then for paracentesis, I would say big bellies, there's a big differential for big bellies, gas, abdominal wall abdominal wall edema, ascites, and just obesity. And so everybody has some combination of that. And so looking with ultrasound lets you figure that out very, very quickly. And then for LP, I think it also helps people in deciding, do they want to even try the procedure? If it's going to be difficult and the patient's moving around, maybe they want to find somebody else. But in many cases where we thought it was going to be difficult, it actually ends up being fairly easy. So I'd say tap into your local ultrasound experts and, you know, collaborate with your colleagues, your intensivists, anesthesiologists. This is a time for people to come together and work together. And it actually, for whatever reason, and it's a good reason, ultrasound takes down a lot of those specialty barriers. People open up and start sharing and talking. Your IR people are a great resource. They've got needles and things that they will give you for free. They're already on the supply list for your hospital. So just go meet with them and you can get some of these kits and needles.
Perfect. Well, we'll wrap up there. Thanks for all our speakers and expertise for joining in. For those of you on joined live here and those on the recordings, there's a CME available and MOC for this session. So again, bedside procedure for clinicians. Hopefully you get to enjoy this from the expertise here. Thanks everyone. Have a good night. Bye-bye.